and I think this one is likely going to be a lot of people's favorite chapter. It's very fascinating to learn about the different psychological disorders and the DSM, which is the book that lists them all. So let's get started. There we go. Wasn't letting me change the slide. We'll start by quickly defining what a psychological disorder is. A psychological disorder is a condition characterized by abnormal thoughts, feelings, and behaviors. Psychopathology is the study of psychological disorders. And harmful dysfunction means that when the dysfunction occurs, something goes wrong either with learning or cognition or perception, it harms the person's life. It breaks down the person's success or happiness or something that will go wrong in their life. It's a harmful dysfunction, not just a dysfunction. So if the dysfunction is harmful, meaning that it leads to negative consequences for them or for others, as judged by the standards of their culture, then it can be qualified as a psychological disorder. So if the person has a dysfunction in thoughts, feelings, or behaviors, something abnormal, which causes harm to themselves or others, and is not judged as normal by the standards of their culture, there's a good chance that they will be diagnosed with a psychological disorder. Over on the right, we can see the APA definition of psychological disorder. It has 4 different parts. The first, as I mentioned, is the disturbances in thoughts, feelings, or behaviors. The second is that these disturbances reflect some kind of either biological, psychological, or developmental dysfunction. The third is that these disturbances lead to significant distress or disability. This is the harm part. And finally, that the disturbances do not reflect expected or culturally approved responses. So it's not normal in their culture. And when we get into some of the childhood disorders a little bit later on, we'll discuss whether they should in fact be labeled as disorders and whether they really meet all of these criteria in terms of disturbances. But anyhow, that's our definition for now. The DSM is the book that psychologists and psychiatrists use to diagnose people with psychological disorders. It's a big fat book full of lots of different disorders, hundreds of disorders in fact, and each disorder has information about the diagnostic features, meaning like the symptoms, and criteria, how often the symptoms have to be, how severe they are in order to be diagnosed, how many of the symptoms need to be present. The prevalence information is how common it is in society. Risk factors for the disorder, comorbidity, I always say that wrong, comorbidity means when 2 disorders happen, 2 or more happen at the same time. So sometimes, for example, somebody with borderline personality disorder is more likely to have substance abuse disorder as well. These are comorbid, they go together. It also talks about gender differences, differential diagnoses, meaning things that could seem like this disorder but it's actually something different. And then finally it describes the typical development or course of the disorder. So as you can see, there's a lot of information about each disorder, and as I mentioned, there are hundreds of disorders, so it's a very big, long book, but any diagnostician in the field of psychology would certainly need to be very, very familiar with this book. This is the edition number 5. There's been several editions along the way, and I'm really hoping that they're going to have another edition soon. It's been almost 10 years since this last edition was published, and as I will mention later, there are some things that are kind of up for question or discussion whether they should be in there as a disorder and how some of the wording is and all of that. We'll talk about that later. So the DSM is the book that is used for diagnoses and to understand all the different disorders. The biological perspective just tells us that psychological disorders are not only something that is a product of our environment, that it's also something that we're born with. And in a moment, we'll talk about the combination of the two, but this shows the biological perspective, showing that psychological disorders are, in fact, genetic. this example shows the percent risk of developing schizophrenia. And as you can see, the closer the relative who's diagnosed with schizophrenia, the more likely you would be to be diagnosed with schizophrenia as well. So, for example, if somebody's parent is schizophrenic, then they would have like a 7% chance of developing schizophrenia. Whereas if someone's identical twin has schizophrenia, it's up to almost 50%. So the more genes that are shared, the more likely you are to have the same disorder as the family member. And this is what shows that there is a genetic component here, that we know it is related to genes, even if we're not sure exactly how. On to the diathesis stress model. The diathesis stress model is basically kind of like nature-nurture. It says that the reason psychological disorder will emerge and happen and someone will be diagnosed is a combination of both the diathesis, which is their predisposition, their genetic, biological chances of getting it, combined with their environment, this amount of stress that they experience or do not experience during their life. So, for example, someone who is a child star, like Demi Lovato, may have been born with a predisposition to have bipolar disorder, and then because they were a child star, they experienced the stress in their childhood and in their lifetime, and therefore the bipolar disorder came out. Had Demi Lovato not been a child star, they might still have bipolar disorder, but they may not. We don't know, because it's a combination of the two that brings it out. And maybe the child acting or being in the public eye brought on enough stress that it pushed them over that threshold to that biological predisposition for bipolar disorder. And in fact, the reason that I put their picture up here is that Demi Lovato has bipolar disorder, and they are a very big advocate for mental health care. They have free mental health care counseling sessions at their concerts sometimes, and really sort of push for destigmatizing mental health and mental illness. So anyhow, I thought they deserved a spot over here on the slide, as well as being a good example of the diathesis stress model, which again, your diathesis is your predisposition, and then the stress is what you experience in the environment in your lifetime. All right, now we're going to talk about all the different disorders. And before we start, I just want to say a short little message that it is very common when learning about psychological disorders to start to think that you have these disorders, or people you know have these disorders. Most likely you do not, and they do not. However, I don't want to take that lightly. I feel like the book kind of brushes it off. Like, well, if you read about this and you think you have it, you definitely don't. You or somebody you know does struggle with mental health and does need to talk to a mental health professional. Please reach out to me if you need help getting in contact with a mental health professional, or if you're worried about your mental health, you can reach out to me or any of the counselors at school. But do remember that it is fairly normal to start to identify with these disorders and say, hey, I do that. Maybe I have OCD, or I do that a lot. Maybe I have that personality disorder. And remember that it has to have that harmful dysfunction. If the symptoms are not significantly impairing your life, hurting you or others in your life, then you probably don't have this disorder. A lot of people have some symptoms or some tendencies of disorders without needing a full-blown diagnosis. All right, I'm done with my little PSA. Let's move on to our types of disorders. Anxiety disorders, very, very common. Excessive and persistent fear and anxiety. I'm sure everybody's familiar with what anxiety is like. If somebody is going to be diagnosed with an anxiety disorder, their symptoms would need to meet certain criteria. We'll talk about the different types of anxiety disorders in a moment with different criteria, but it's very common. In fact, 25 to 30% of the population in the U.S. at some point during their life will meet the criteria for at least one anxiety disorder. Very common. Lots of celebrities talk about their anxiety, and hopefully as more people talk about it, more people will treat it and get it under control. Let's look at the different types of anxiety disorders. Specific phobia is a fear of a specific object, usually something that doesn't present a huge risk in itself, and the person's fear is over the top, more than it should be for the amount of danger that's present. For example, my mom is so terrified of snakes that she cannot even say the word snake, which obviously is not a threat to her to say that word, but she's so afraid of it that she can't look at a picture or say the word or think about a snake or anything. This could be a specific phobia, fairly common, lifetime prevalence of 12.5%. But remember, to be diagnosed, it has to significantly impair your life. My mom never went ahead and got a diagnosis on a specific phobia because she doesn't encounter snakes in her life. It doesn't really negatively affect her life. If she lived somewhere where running into snakes were common, perhaps she would have needed a diagnosis. And as the book mentions, sometimes a specific phobia is related to a trauma or an experience or classical conditioning. There's different explanations, but sometimes there doesn't seem to be an explanation. It seems to be out of nowhere. Interestingly, people are a lot more likely to develop phobias of things that do cause at least a little bit of danger, like spiders or snakes, as opposed to things that cause very little danger, like bunnies or ladybugs. All right, moving on to social anxiety disorder. I think this one's fairly self-explanatory. Fear and anxiety related to social situations. The kind of key on this one, on social anxiety disorder, the key factor here is that the person avoids social situations because they're worried that other people are going to think badly of them. That's the main reason for avoiding the social situation, is they're worried about judgment, worried that other people will think badly, negatively of them. So that's the main reason that they choose to stay away from social situations. Moving on to the green box in the middle, panic disorder and panic attack. So let me actually start on the bottom with panic attack. Many of you may have experienced that. In fact, close to 1 in 4 Americans experiences at least an isolated panic attack within their lifetime. It can feel like a heart attack sometimes, accelerated heart rate, sweating, trembling, feeling like the person can't breathe. They can feel hot or have chills, maybe dizzy. And then especially if the person's not familiar with what a panic attack is, this is very, very scary and then causes more panic, right? So having a panic attack is very common. However, panic disorder is less common. Panic disorder is where the panic attacks happen more than once. They happen recurrently, as well as regular persistent concern about the panic attacks. So even between attacks, the person is anxious about having a panic attack. They may avoid triggers or avoid being alone or in places where it could be dangerous to have a panic attack. This is panic disorder. Over onto the pink side, generalized anxiety disorder. This is the kind of continuous state of excessive anxiety. So it's not triggered by the panic attacks or by a snake or a rat, and it's not triggered by social stuff. There's nothing specific that causes the anxiety. It's just a constant excessive worry. And often then they worry about worrying, and as you can imagine, this is not an enjoyable thing to endure. Generalized anxiety disorder has a fairly low lifetime prevalence of 5.7%. To be diagnosed with GAD, the person has to experience symptoms more days than not for at least 6 months, and then it's accompanied by any of the 3 symptoms, any 3 of the symptoms from the list: restlessness, difficulty concentrating, easily fatigued, muscle tension, irritability, and sleep difficulties. So as you can see, there's specific criteria that need to be met in order for a diagnosis to be given for any disorder. This is just an example for GAD. Moving on to the next type of disorders, that was anxiety disorders. Now we'll move on to obsessive compulsive and related disorders. This is a group of overlapping disorders that usually involve intrusive thoughts as well as repetitive behaviors. And the key here is that the behaviors are an attempt to stop or distract from or deal with these intrusive thoughts. So you may hear, this is one of those disorders that's often overused in popular culture or in regular conversation. People might say they have OCD if they like everything to be totally straight on their desk. And in fact, we'll talk about obsessive compulsive personality disorder later at the end of the chapter. It could be that, but somebody wanting things to be neat or a certain way all the time, or needing their volume set at a certain number, or even double, triple checking that they've locked their door before they leave the house. None of that is obsessive compulsive disorder unless the reason that they're doing it is to help with the intrusive thoughts that they're having, with these obsessions, these obsessive thoughts that are coming in their mind. If the reason for the behavior is to combat those thoughts, then they may be diagnosed with obsessive compulsive disorder. Although it does get a little complicated, because once in a while there can be a diagnosis with just the obsessions or just the compulsions, but normally the person would have both. Very low lifetime prevalence of 2.3%. So again, let's go over our definition real quick. Thoughts and urges that are intrusive and unwanted, those are the obsessions, and or the need to engage in repetitive behaviors or mental acts, compulsions. So it's like they can't stop themselves from doing these things. So the obsessions are persistent, unintentional, unwanted thoughts, and very common obsessive thoughts for patients with OCD are when the person can't stop thinking about that they have the power to do something bad if they wanted to. So they don't want to do something like take out a knife and stab somebody, but the fact that they know they can't stop thinking about that. That it upsets them that if they wanted to, they have the power to take a knife and stab somebody to death, or to drive their car off a cliff, or to stop going to work and lose their job. They keep thinking about the fact that they could do those things if they wanted to, even though they don't really want to do those things. Those are examples of obsessions, those intrusive thoughts that can often result in compulsions, repetitive and ritualistic acts, usually carried out as means to minimize the distress of the obsessions, right? So not always, but almost always, these compulsions, these behaviors, the reason that they're done is to help the person cope with the stress and anxiety and fear brought on by the obsessions, by the intrusive thoughts. Moving over to body dysmorphic disorder, it's a related disorder, but obviously quite different. Basically, body dysmorphic disorder is when the person is preoccupied with a perceived flaw in physical appearance. So, emphasis on perceived here, because the flaw is either non-existent or barely noticeable. So if somebody does have, let's say, a big mole on their face, or they're balding and they're very self-conscious about it, this wouldn't fall under body dysmorphic disorder, because the thing that they're worried about, even though it might not be nearly as big of a deal as they think it is physically there. Body dysmorphic disorder it's something that's not even there. Like maybe they have a teeny tiny brown dot on their face and they think that it's this huge big mole that everybody's staring at, and most people who know them never even noticed it before. That would be body dysmorphic disorder. Or somebody who looks in the mirror and they think that they have wrinkles all over and they look so old, but everybody else who knows them thinks that they look very young. This would be body dysmorphic disorder. So it's a perceived flaw that's non-existent or barely noticeable. Finally, hoarding disorder. If you've ever seen the TV show Hoarders, you're probably familiar. The person has a very hard time getting rid of things and keeps things that are useless, or create so much clutter in their house that it impairs their functioning. So remember, again, harmful dysfunction, right? You're only going to get a diagnosis of hoarding disorder if the person's hoarding significantly impairs their life, significantly affects their life in a negative way. All right, PTSD, I believe we talked about a little bit in a previous chapter. It's different from the other disorders because it has a cause. Normally, a psychological disorder doesn't have a cause. For example, generalized anxiety disorder, the person is anxious all the time for no reason. There's usually, by cause, there could be a biological cause or something, but it's not related to a certain event. It's not triggered by one day this happened and then the person has the disorder. PTSD is an exception. PTSD, in order to be diagnosed, the person has to have experienced trauma before. So trauma can include things like combat, going to war, threatened or actual attacks, assaults, natural disasters, accidents, anything that basically either put the person's life at risk or made them think that their life was at risk counts as a trauma and can result in PTSD. And a lot of people are surprised by the fact that PTSD is a lot more common in women than men, because I think the general public often associates PTSD with the military, which most people generally associate with males. However, it is in almost 3 times more common in women than in men, and I'm not 100% sure of this, but I suspect that it has to do with sexual assault and attacks and that kind of thing. Violent attacks and stuff like that women are more likely to be the victim of. All right, symptoms of PTSD: intrusive and distressing memories of that traumatic event, including flashbacks. The person can avoid things that are connected to the event. For example, if somebody was robbed at gunpoint and that was their trauma, they might not want to watch shows or movies that involve somebody getting held up at gunpoint. Persistently negative emotional states, detachment from others, irritability, outbursts, jumpiness, like the exaggerated startle response. So for PTSD to be diagnosed, these symptoms must occur for at least a month. So basically it's normal for a person to have some of these symptoms for a little while after a trauma, but if it continues for more than a month, they will likely be diagnosed with PTSD. All right, mood disorders in general are depression, depressive disorders, and then bipolar. So depressive disorders is where the person is just depressed. They just have the downside of the mood disorder. Depressed people feel sad, discouraged, and hopeless. These individuals lose interest in activities that they used to enjoy. They often experience decrease in hunger or sex drive, doubt their personal worth, and as we'll mention in a little bit, the scariest symptom of depression is suicide or suicidal thoughts. Bipolar disorder is different than depression because it has to involve mania. Usually it involves both manic stages and depressive stages, but to be diagnosed with a bipolar disorder, at the very minimum, the person needs to have manic periods. So mania is a state of extreme elation and agitation. When people experience it, they can become very talkative, behave recklessly, spend a lot of money, do a lot of things at once, stay up for hours or days on end. You can see the symptoms at the bottom. I'm not going to go through all of them. I assume you're fairly familiar, and we're going to talk more about bipolar in a bit. Let's look at the different depressive disorders. Major depressive disorder, where the person has a depressed mood most of the day, nearly every day. This one is fairly high. In fact, your textbook calls it the common cold of mental illness. Major depressive disorder, quite common. 16.9% of people will experience it during their lifetime. Seasonal affective disorder or seasonal pattern depressive disorder is when the person's symptoms only happen during a certain time of year. Typically, this is winter time in places that don't get a lot of sun, have short days. The people don't go outside as much. We're very lucky in Hawaii. Seasonal affective disorder is extremely rare in tropical climates like ours. Peripartum, also called postpartum depression, occurs during pregnancy or after pregnancy. The book says 4 weeks following, but postpartum depression can last, in fact, sometimes for several years after pregnancy. But I think to be diagnosed with it, it needs to be within a certain time frame after the birth of somebody's child. The parent who had the child often feels guilty, agitated, they cry all the time, and in extreme cases, the mother might want to hurt the child. So sometimes you may hear those very sad news stories where a mother kills her children. Often in this case, there's a newborn in the picture, and the mother is suffering from postpartum depression that makes her go as far as actually killing her own children. Of course, that's a very extreme case. Postpartum depression is fairly common in different levels. and it's something that women should definitely be encouraged to talk to their doctors about after having a baby. Persistent depressive disorder. This one is depressed moods most of the day, nearly every day for at least 2 years. So this one lasts 2 whole years, as opposed to the major depressive disorder, which is usually which I believe is 2 weeks. So 2 weeks of depressive symptoms, more days than not, is a major depressive disorder, but 2 years, at least 2 years would result in a diagnosis of persistent depressive disorder. Over on the right, you can see the criteria to be diagnosed with major depressive disorder. Oh, this is where it says the 2-week period. You don't need to know all of these details. This is just sort of to show you an example of what the criteria looks like in the DSM. Bipolar, as I mentioned, needs to have manic stages, manic episodes, and often has depressive episodes as well. During a manic episode, a person often spends a lot of money, doesn't sleep very much, does all sorts of different things, buys things they can't afford, gambles, or has sex with people they don't know, or with lots of partners, speaks quickly, very irritable. You can see all the different signs of a manic episode down here. And this one is not common. It has a prevalence of 1%. Although if you're familiar with the show Shameless, I put a picture of Ian over here. Both Ian and his mom suffered from bipolar disorder and had very erratic behavior during their manic episodes. And I remember the mom at least had definite deep depressive episodes as well. All right, as I mentioned a little bit earlier, the scariest side of mood disorders is suicide. The National Suicide Prevention Lifeline, which is available 24 hours, the number's up here, 1-800-273-8255. You can call anytime. They have translators available if you don't want to speak in English. If you're worried about yourself or anybody you know, please don't hesitate to call this number. As you probably know, suicide is death caused by self-directed injurious behavior with the intent to kill themselves. Not only must the person be biologically or psychologically vulnerable in order to do this, they need to have the means to do it as well, and they must lack the protective factors. It's not listed as a disorder in itself. However, 90% of people who commit suicide have a diagnosis of at least one mental disorder, with mood disorders, of course, being the most common. Suicide was the 10th leading cause of death for all ages in 2010. It's 4 times more common among males than among females, so much, much more common among males. For males, using a gun is the most common method, whereas for females, poisoning is the most common method, or overdosing, purposely overdosing. Contrary to common belief, Christmas season is not the highest rate of suicides. In fact, it's springtime. People with alcohol dependence, 10 times greater risk. And here's the important part at the bottom, all of this was important, but the most important part are some signs to look for, some reasons that you might want to call that number up there if you're worried about somebody you know. Some signs are withdrawal from social relationships, feeling as though one is a burden to others, engaging in reckless and risk-taking behaviors. If you're worried about somebody and they have these symptoms, you may want to reach out to them or reach out to the hotline. All right, moving on to schizophrenia. Schizophrenia is a very important one, especially for your 3rd exam. I recommend being familiar with the symptoms of schizophrenia. Schizophrenia is a psychotic disorder, not very common, but very, very disturbing, very obvious. Usually, if you know somebody with schizophrenia, it's usually a lot more obvious than something like an anxiety disorder. Someone who suffers from a psychotic disorder is disconnected from the world in which most of us live. So the main symptoms of schizophrenia, and I'll go over them in detail in a little bit, the main symptoms are hallucinations, delusions, disorganized thinking, disorganized or abnormal motor behavior, and negative symptoms. I'll go over all of those in detail in a moment. Schizophrenia definitely has a genetic basis, as I showed in the biological perspective slide. If someone has an identical twin who's been diagnosed with schizophrenia, there's almost a 50% chance that they will have schizophrenia as well. Definitely a high genetic basis. However, there have been lots and lots of studies that have basically confirmed that there is also environmental basis. It's a combination of both. So somebody with that genetic risk of schizophrenia who lives in a low stress, high nurturing environment will be less likely to end up with a diagnosis, end up with the symptoms, as somebody who lives in a not so good environment. So it's a combination, like most of these psychological disorders, it's a combination of biological genetics and the environment that you live in. People with schizophrenia do have lots of physical things that can be noted, though. Differences in neurotransmitters and brain abnormalities. There's been correlations with complications during the mother's pregnancy. They talk about all of that in the book. Interestingly, it's basically been proven that there is a causal relationship of marijuana to schizophrenia, meaning that it's not just correlated, that they think that using marijuana can increase the chances of having schizophrenic symptoms. However, the theory is mostly, or most likely, a lot of theories tell us that it's most likely that the person is born already with that predisposition for schizophrenia, and using the marijuana just triggers it to start happening. And it likely would have happened anyway. The symptoms would have shown up anyway, but the marijuana use triggers it to happen earlier. They're still doing research on that, but there is definitely a relationship between the two. However, this wouldn't be a reason, really, unless somebody has a high likelihood of getting schizophrenia. I can't imagine not using marijuana just because you want to avoid getting schizophrenia. It's not that high of a risk. But you can see the little graph down there. All right, moving on to the symptoms, the important part for your exam, and I think the interesting part, but very scary as well. I've always kind of had a fear of getting schizophrenia because I could imagine it would be terrifying. One of the main symptoms is hallucinations. A hallucination is a perceptual experience that occurs in the absence of the external stimuli. So remember in the sensation and perception chapter, we learned that the stimulus is there and then we perceive it. A hallucination is where the stimulus is not there, but the person perceives it anyway. For example, auditory hallucinations are hearing voices. Nobody's really talking, but the person hears voices. There are visual hallucinations or even olfactory hallucinations where they smell something that's not really there. But the most common is hearing voices. It's very common in schizophrenic patients to hear voices. Sometimes they hear a running commentary of what they're doing. Sometimes they hear voices suggesting things to them. Sometimes it's their own voice. Sometimes it's other voices or unfamiliar voices. Anyhow, auditory hallucinations, very common in schizophrenia. The next symptom is delusions. Delusions are beliefs that are contrary to reality and firmly held even in the face of contradictory evidence. So not just a difference of opinions or believing in something that you don't believe in. Maybe your friend believes in horoscopes or psychics and you don't. But a delusion is more like refusing to see the other side and thinking something very, very abnormal, such as thinking that there are agents following you everywhere you go, or thinking that you were abducted by aliens. These would count as delusions. Sometimes there's delusions like thinking, well, you can see the different types of delusions down here, actually. Delusions of grandeur, when the person thinks that they have real power to control others or control the world. Delusions of ideas of reference, where they think that people on TV are talking to them or articles in the newspaper are meant for them, messages for them. Delusions of persecution, this is like paranoia. They think people are out to harm them. Excuse me. Somatic delusions. Somatic means like symptoms. So they think they have physical disorders or symptoms that aren't there. They might even think that they're blind or deaf when in fact they're not. Thought broadcasting, when they think other people know what they're thinking. thought insertion, belief that someone's putting ideas in their mind, and thought withdrawal, the belief that someone's taking thoughts from their mind. These are all different delusions. As you can see, these are not normal things to think, that somebody's stealing your thoughts or that people are putting transmitters in your teeth to monitor what you're talking about. These would be delusions and a definite red flag for schizophrenia. So the first two, remember, were hallucinations and delusions. Next is disorganized thinking. Usually this is the way you can tell that somebody has disorganized thinking is through their disorganized speech. Their speech doesn't make much sense. One word reminds them of something else. It almost sounds like they're playing that association game where you have to say the first word that pops into your head when you hear another word. And they're not actually speaking, like, their sentences don't mean anything. Their words don't have any meaning. They're just saying what, at least to everybody else, sounds like random words. So this is disorganized thinking, characterized by disorganized speech. The fourth symptom is disorganized or abnormal motor behavior. So how the person moves. They might exhibit silly childlike behaviors or do repeated movements over and over. Sometimes odd facial expressions or gestures, and sometimes catatonic behavior where they basically act like a statue. They go into like a strange position, like maybe their arm is up in the air and their leg is sticking out, and they stay totally still, frozen like a statue for a long period of time. So catatonic behavior is one example of the disorganized or abnormal motor behavior. Finally, the fifth symptom of schizophrenia is negative symptoms. And then this is actually broken down into 5 types of negative symptoms. But in general, negative symptoms mean that it's a decrease or absence in behaviors or emotions or drives, things that the person used to do or feel or want, they don't do or feel or want anymore. It's gone away, which is why we call it negative. So, for example, they could have diminished emotional expression where their face looks blank no matter how they say they're feeling, no matter what words they're saying. Avolition is the lack of motivation to take care of their own grooming needs, like showering and brushing teeth, shaving, stuff like that. Alogia, reduced speech output. Sometimes they may even stop speaking entirely. Asociality is withdrawing from social situations. And ahedonia is not being able to experience pleasure. Things they used to like, hobbies or interests, favorite foods, sexual activity, they no longer can experience pleasure from these things. All right, so those were our schizophrenia symptoms. Now we'll move on to dissociative disorders. Dissociative disorders are characterized by being split off or dissociated with the person's sense of self or with the world. Dissociative amnesia, the person forgets who they are, basically. They don't know their name, they don't know where they're from, they don't know their address, they lose their sense of identity. Of course, this is very stressful. It can often happen right after traumatic experience, and it's usually short-lived. It usually only lasts for a couple hours or a day. Dissociative fugue is where the person takes off. They don't know who they are, so they go wandering trying to figure it out. It's a normal kind of reaction to the dissociative amnesia. They wander away from their home. They don't know who they are. And sometimes, because they don't know who they are, they make up a new identity because they feel like they need to tell people that they have a name, right? And an identity. Over to depersonalization, derealization disorder. This is recurring episodes of one or both. So depersonalization is when the person feels detached from themselves, like they're floating up above themselves, watching themselves with no control over their own behavior. And derealization is where they feel detached from the world, like they're living in a dream, they're powerless, they are imagining it, like that, like a fog sometimes. So that's depersonalization, derealization. If one or the other happens, it's considered together depersonalization, derealization disorder. And then dissociative identity disorder, you may have heard of in mainstream culture, although it often is depicted poorly and inaccurately. Dissociative identity disorder is also called multiple personality disorder. Almost always, if not always, the person who experiences dissociative identity disorder experienced very severe trauma as a child. In fact, I made the mistake of reading some of the articles about dissociative identity disorders, causes and precursors, and some of the stories that these people told of what they had to endure as children will definitely haunt me for the rest of my life. It's not regular trauma usually. It's very, very severe trauma that they incur as a child. And the theory is that they need to create these other identities, or at least one other identity, in order to escape the mental trauma and the physical trauma that they are enduring as a young child. And these identities stick with them even after the trauma ends. Some people can have dozens of identities. Some people only have 2 or 3. There have been some pretty good documentaries about dissociative identity disorder. And there was a show, United States of Tara, that I think did an okay job of depicting it. But the person changes sometimes genders, age, sexuality, and sometimes even some physical things will change. Like one of their identities will have high blood pressure and the other one won't, or one of them will need glasses and the other one won't. And as your book mentions, it has in the past, some people have faked these symptoms to try to get out of legal trouble, but it is definitely a real disorder that does happen. It's not very common, but it does happen. And the person transfers from one identity to the other and often doesn't have a memory of what happened during their time as the other identities. All right, moving on to childhood disorders. This is where I'm going to disagree with kind of the book and the definition of all of this, in that I'm not sure these definitely should count as disorders. We're going to talk about ADHD, and then we're going to talk about autism. And I'm also going to share with you folks a video of I'm not sure if it's a TED Talk, but a talk by an autistic woman who explains several things, such as why she prefers to be called autistic and not somebody with autism. She also explains why she doesn't see it as a disorder. And anyhow, let's talk about ADHD real quick, and then we'll talk about autism. I'm sure you're familiar with ADHD, attention deficit hyperactivity disorder. In the old DSM, you could have ADD or ADHD. That's no longer a thing. Nobody's diagnosed with just ADD anymore. Everybody's diagnosed with ADHD, but you can have the hyperactive type or not. So even if the person is not hyperactive, technically their diagnosis still has the H in it. It's just the non-hyperactive type. So a child with ADHD has a lot of varying symptoms. Let's look at the list here. Trouble holding attention on tasks or activities. Sometimes seems like they're not listening, doesn't follow instructions, trouble getting organized, losing things, distracted, forgetful, fidgeting, squirming, running about, talking a lot or interrupting, trouble waiting their turn. And in fact, there are a lot of other common symptoms, such as having trouble with time management and multitasking. And there are definite biological components to ADHD. A lot of people with ADHD respond very, very well to medication. The medication can be life-changing for a lot of the inattentive and hyperactive symptoms. However, as you'll see, as the woman mentions, I have another video about ADHD. I'll post that one too, because that person talks about, I forget who they are, but that person talks about how as an adult, they still had a lot of the symptoms that went away with the medications. I mean, they still had other symptoms. A lot of the symptoms went away with the medications, but they still had symptoms like time management problems that don't go away with the medication. ADHD is fairly common, 5% of children, that's 1 in 20, that's at least 1 in every classroom. Boys are 3 times more likely to be diagnosed. I don't like to really say that they're more likely to have ADHD because there's a lot of evidence that it's just that they're more likely to be diagnosed as opposed to more likely to actually be born with ADHD. It can certainly persist into adolescence and adulthood and is often comorbid, which, if you remember, means more likely to happen with other things. It's comorbid with other disorders as well. ADHD also, interestingly, they've recently found a possible genetic link between ADHD and autism. For example, I read a study that found that if somebody's parents have ADHD, they're more likely to be autistic. So moving on to autism, again, the book calls it a disorder. The DSM and the World Health Organization's psychological manual both refer to it as a disorder, and they both talk about symptoms such as significant disturbances. But as you'll see in the video that I'm going to post on La Lima, a lot of autistic people argue that this isn't a disturbance, it isn't a deficit, it's a difference, and that maybe the world needs to be a little more ready for them as opposed to expecting them to change everything about who they are. I always like to point out that most, if not all, of the richest people in America have either been diagnosed with autism or believe that they are autistic, even if they haven't received a diagnosis. So the way I always put it is, if Elon Musk and Jeff Bezos are wrong, I don't want to be right. And in fact, I don't really want to be just like them. But obviously it's not purely a disorder if one of the symptoms is being a billionaire, right? Maybe there's some good side of this as well. Again, I don't want to talk too much for the autistic community. I will let them do that themselves in the video that I post. But I will share with you what the book says and what the DSM says, because while I don't necessarily agree with the wording or the vocabulary, this is the current definition. So the definition of autism spectrum disorder is having three things: deficits in social interaction, deficits in communication, and repetitive patterns of behaviors or interests. These disturbances appear early in life and cause serious impairments in functioning. You can see that it's a spectrum, and they range from high functioning to what is often called severe autism. Again, from what I understand, the autistic community, not a huge fan of this wording here, but I don't want to speak for them. It is becoming a lot more diagnosed. It does appear to be strongly influenced by genetics. In fact, identical twins show concordance rates of up to 90%, meaning that if one twin is autistic, there's a 60 to 90% chance that the other one will be as well, which means it's definitely genetic. However, there can be some environmental factors. Research still going on about that. And as you'll see in the video, the autistic woman mentions that most of the research for autism related to autism is looking for a cause, and she thinks, as well as a lot of other people in the autistic community apparently think, that the research should be focused on not necessarily on fixing it, because it's not a problem that needs to be fixed. Why are we just looking for causes and ways to make it better? Why can't we be focusing research on how to make society more conducive to autistic people? One thing we do know for sure from all of this research looking for causes is that there's no relationship between vaccinations and autism. That's been debunked. There were people who thought that a while ago, and there's definitely no relationship between vaccinations and autism. All right, I'm going to move on, although I just want to remind you real quick to watch the video about autism that I'm going to post on La Lima, and maybe you can sort of think for yourself or decide for yourself whether you think it should be considered a disorder or perhaps just a difference. Our last slide, I think we have two slides, but our last topic is personality disorders. A personality disorder is a personality style, something that's persistent, usually starts in adolescence or early adulthood, and it basically covers the person's whole life because it's their personality, but it's not normal, basically. I know that sounds bad, but it's different from what is accepted in society. So it differs markedly from cultural expectations, pervasive and inflexible. So the person's not able to change this aspect of their personality to get along better with other people. It can cause disturbances in their life, Because remember, in order to be diagnosed with any of these things, the person would need to have that harmful dysfunction, right? That it would need to harm them or other people in their lives. So let's talk about the different types of personality disorders. There's 10 of them, and they're split into 3 different clusters. Cluster A are the odd or eccentric disorders. Cluster B are the dramatic, erratic disorders, and Cluster B are the anxious and fearful disorders. So the people with the odd or eccentric ones, actually, I'll talk about them in a minute. I'm going to go over all of them on this next slide, and then we will be done. I know it's really long. I'm sorry. All right, let's talk about the 10 different ones. So those first 3 are part of the odd or eccentric cluster, and these 3 basically are parts of schizophrenia. It's almost like the person has just one of the 5 schizophrenia symptoms. So instead of being diagnosed with schizophrenia, they're diagnosed with either paranoid, schizoid, or schizotypal personality disorder. So paranoid, the person has chronic pervasive distrust of other people. They're always suspicious. They think they're being cheated on or followed or listened to. And again, that's a common symptom in schizophrenia, is to have paranoid delusions, right? But in this case, the paranoid delusions are the only symptom. They don't have the other symptoms of schizophrenia, so this person would be diagnosed with paranoid personality disorder. Schizoid personality disorder, this is all of those negative symptoms that we talked about. Social isolation, not a lot of relationships, preoccupied with being by themselves, introspection. They might seem cold to other people. They're not into socializing at all. Social isolation is the main thing, the main symptom of schizoid personality disorder. And then finally, schizotypal is sort of the strangeness. And I don't really like the word strange because I feel like, I don't know. Anyway, schizotypal personality disorder can involve odd speech or behavior, odd appearances, very strange outfits sometimes, strange beliefs, difficulties forming relationships. So again, similar to schizophrenia, but missing a lot of the criteria needed for a diagnosis of schizophrenia. Moving on to the next cluster, which is the erratic, dramatic, attention-seeking cluster. This one has 4: antisocial, borderline, histrionic, and narcissistic. So antisocial personality disorder, I've heard this term thrown around incorrectly as well. Sometimes people think it means you don't want to be social, but in fact that one is schizoid, right? The schizoid people socially isolate. What antisocial means is that the person doesn't care about other people at all. It's almost like they're evil. Like they really only see other people as a means to get what they want. They'll hurt other people physically or emotionally or financially. They use other people, and they don't show remorse afterwards. Probably not all, but I would guess most serial killers would be diagnosed with antisocial personality disorder. They kill somebody and they don't even feel sorry about it afterwards. That lack of remorse is the big red flag for antisocial personality disorder. Borderline personality disorder, quite different. This one is an instability in relationships, and this one's kind of hard to explain. I don't really like the definition here. This, to me, the best way to remember borderline personality disorder is the person is right at that borderline to like losing it, to getting really upset. They get angry very, very easily. They could blame others. They may even get clingy. They're very irritable, likely to yell a lot, like even it seems like something small sets them off, and very unstable in their relationships, as you can imagine. One of those like, go get out of here, I hate you, 2 minutes later, no, come back, I love you. There's a good chance that person would have borderline personality disorder. Histrionic personality disorder, actually named after the uterus, but it can happen. It can be apparent in. It can happen in males as well as females, but it was originally sort of stereotyped for females. This one is so the person's excessively emotional. They attention seek a lot. They do lots of socially inappropriate behavior. Often they may seem like they're having a manic episode, like we talked about earlier. They talk a lot, they interrupt, center of attention, they engage in risky sexual behavior a lot of the time. But in this case, the reason that they're doing it is that they want attention. They're doing it to try to seek attention from other people. So that's histrionic personality. And then narcissistic, another term that gets thrown around a lot. I hear people using this one a lot, but it is a thing, and I wouldn't want to be in a relationship with someone who has narcissistic personality disorder, that's for sure. They're self-centered. They think that they are the best, that they can only be understood by other super smart, wonderful people, that the average person doesn't get them, that they're going to have tons of power and success and leave everybody else behind. This person will often, it often comes from actually having low self-esteem, but they come off as being the most self-centered, most confident, highest self-esteem person there is. It's like a super overcompensating for their low self-esteem. They really truly believe that everybody loves them and everybody talks about them all the time, and that they're more special than other people, and you should be so lucky to be with them. All right, moving on to the last cluster is the anxious and fearful cluster. Avoidant personality disorder. This person is avoiding social situations because they feel like they're inadequate. Somewhat similar to what was I was talking about? Social anxiety. Somewhat similar to social anxiety, but they don't necessarily have the high levels of anxiety. They just are not interested in hanging out with other people or being in other groups because they're worried about being criticized. Dependent personality disorder, very clingy, scared of being alone, always trying to get other people to take care of them. They'll even threaten to hurt themselves if you leave them because they really don't want to be alone. And finally, obsessive compulsive personality disorder. I mentioned earlier, different from obsessive compulsive disorder. That one, remember, the thoughts, the obsessive thoughts are what cause those ritualistic behaviors to try to make the person feel less anxious about the thoughts. This one is more of just a preoccupation with everything being neat and clean and orderly, or just having like obsessions with to the point where it's affecting your life, right? Remember, for all of these, it has to be affecting your life. So if someone needs to keep their stapler at a 90-degree angle on their desk, that's fine. But if they're spending 2 hours every day after work organizing their desk and missing family dinners with their wife and kids because they're so busy reorganizing their desk, they might be diagnosed with obsessive compulsive personality disorder, since it's negatively affecting their life. All right, I'm not going to go over the summary on this one. It is super duper long. It's